Okay, hello everyone. It's Jordan Boxer here from Designs for Sport, and I'm very excited to welcome on our Masterclass, expert, lecturer, Dr. Nikole. What do you want to be known as?
Yeah, Dr. Nikole, Dr. Kokes. I think Dr. Kokes is probably the most relative one.
So I'm really excited for today, actually. We're going to be doing, I think, an often overlooked topic, especially in sports performance, which is considerations for specifically the female athlete. This is a topic I believe that's really close to home for you and something that you've been passionate about for quite a few years. Do you want to go a bit into your background before we get started, or do you have that baked into the presentation?
It's baked right in.
Okay, so let me go over a quick couple housekeeping rules. For all the attendees, you're going to be muted. Please stay muted during the talk. We are going to have some time for a Q&A. If any questions do come up throughout the talk, feel free to type them in and we'll be able to address those. And then we'll be opened up to sort of a little bit of back and forth between us and the attendees when the presentation is over. So no one's really here to hear me speak, Dr. Kokes, so I'm going to hand it over to you. And yeah, see everyone on the flip side.
Amazing. Thank you so much, Jordan. So yeah, this is really near and dear to my heart. And, you know, through my athletic career, these are some things that I've been considering. And yeah, sorry, I just had a screen share moment. Jordan, are you still there? Can you?
I am here. I don't know where your screen just went. It was loaded.
Everything was good to go there.
Gina, who's our technical wizard in the background, do you have any feedback on what we could do right now? There we go.
Hey, we're back. Okay, here we go. Tech is certainly not my forte, but hopefully female athlete considerations are my forte. So yeah, this is something near and dear to my heart. And I think the highlight of this initial slideshow is the considerations part. So everything that I talk about in a female context is something for you to consider. Put it on the back burner, start thinking about it when you're working with female athletes. With all the research coming out, nothing has really been set in stone yet. So anything I say, don't take with a grain of salt, but certainly speak to the athlete in front of you and consider, you know, their presentation and what their complaints are, and that will be the guiding light of your decision versus, you know, these steadfast approaches to changing everything that you're doing on a female athlete context. So the consideration part here is key for me. The other thing I like to always say is I speak fast. There's so many things to cover in this presentation, and I want you guys to have a broad context of some of the highlights, whereas in future presentations, perhaps we'll get a little bit more into the nitty-gritty or condition-specific presentations as well. So I'm going to try to cover as much as I can here. So yeah, my name is Nikole MacLellan. Dr. Kokes is my nickname and probably a lot of my social that I refer to. I'm a naturopathic doctor. I'm a registered dietitian of Canada and certified sports nutritionist. On social media, these are some of the handles that I go off of. Glass Lion is a program that I've started for young female athletes, just educating them about their body, definitely some things that come up throughout puberty, and some local athlete highlights from my hometown of Halifax, Nova Scotia. The Off-Season podcast is a podcast that I've developed talking about athletes and their stories through corresponding with medical professionals, actual athletes themselves, people who have transitioned out of sport and what they're doing now. And then my sports have been hockey, ringette, soccer, golf, and cycling, definitely closer to the golf and cycling side of things these days, and then some beer league hockey to throw in the mix at times. So what we'll cover today is relative energy deficiency in sport. I'm not going to beat that one too hard. I know you guys have heard about it before and have a pretty good understanding of what's happening there. We're going to talk about under recovery. We're going to talk about that HPA and HPG axis, puberty changes that coaches should be watching out for and professionals should be watching out for. We'll do a light dusting of the menstrual cycle. There's so much to that, and there's so many reference points that you could start to get into. So I'm just going to kind of go over it quickly quickly. Performance and cycle training, cycle and nutrition considerations, perimenopausal athlete considerations, testing, what we should be looking at, male coaches, and that's just a few insights on my behalf that I like to shout out and like to consider. Some frequently asked questions, and then I also have a case study that we'll start with and then recap at the end. So one of the most insightful things that really started to push me on towards some of this research is I was doing a little bit of counseling for the UFC Performance Institute, and they were having female athletes that in cut fight week with max amount of effort, some body compositions weren't changing, and that's probably the most highlighting metabolic dysfunction that we could ever consider. So you're at a nutritional deficit, you're training max load just before fight week and then maybe a little bit into the beginning of it, and we're seeing these metabolic changes where body composition just wasn't adjusting. Female athletes weren't making weight. So in this one instance, this is exactly what we're talking about. Loss of menstrual cycle, this female athlete couldn't compete because she couldn't make weight, and not only was she not close, she was just so far away based on doing everything right leading up into. And then we're talking about refeeding and what that could look like, but at the end of the case study, I'll walk you through what we did to get her there, and she didn't make weight, she wasn't able to compete. So all of this is really important to start to consider when you're working with these athletes and what we want to look at. So relative energy deficiency in sport, like you guys have read this tried and true probably so many times. The main thing that I like to highlight is this is one arm of the process. So when we think about recovery, everything gets pulled back to relative energy deficiency in sport, and that's not wrong to do. There's just so many other avenues that we have to consider when we're looking at recovery and performance for a female athlete. So as you know, kind of baseline, we need to eat enough food. Have I seen a lot of athletes that are hitting protein targets and calorie targets? No. So this is certainly someplace that we want to look at. One thing is the long-term consequences of relative energy deficiency in sport, and there's such a graphical representation of performance and longevity that probably meet on a scale somewhere. So I really like to say, like, even though you're feeling fine right now, the long-term consequences of underfueling for such a long period of time certainly play into future fertility, future bone health, all that sort of stuff. So sometimes when you bring it into context, when we're looking at long-term consequences, the athlete can kind of grasp it a little bit more. And when working with younger athletes, it's key that parents understand this too. So with the demands on young athletes, I hear so many times in clinic that they're playing, hockey, ringette, basketball, they're going every single night of the week, and their appetite might be low. So almost initially training their bodies to eat enough food is part of their ability to perform at this level and be involved in so many things, if the parent is going to continue to allow them to be involved in so many things. Whereas a certain conversation might have to be had of that's too much for, a young athlete to do if we're not able to meet the recovery appropriate for that. So under recovery, in a lot of functions, we'll call this burnout, we'll call this overtraining, but I really believe it's an under recovery issue. I think the bodies are able to do such amazing things, but we really want to watch how we're responding to load and how we're able to navigate what that athlete needs. So when we talk about under recovery, there's kind of, some main areas that I look at. The neuro and circadian rhythm is a big one. So that sleep-brain axis has a huge impact on recovery. Some of the main things that I start to hear when I'm assessing this, or questions that I would ask, would be like, the athlete has trouble falling asleep, can't stay asleep. That 2 to 3 a.m. wake up seems to be a big issue for a lot of these athletes. We'll start to notice neurodegenerative changes like word recall issues, memory issues, executive planning dysfunction, mood changes, and the motivational piece really tends to play into this as well. On the reproductive side of things, so we're looking at period changes, missed periods, sex drive diminishes, an increase in PMS symptoms can be a big one there too. Digestion and inflammation, almost every athlete that I work with has some sort of digestive complaint in some capacity. So that could be as simple as, diarrhea, constipation, bloating, urgency while training, like having to run off a lift and go to the bathroom. Inflammation, water retention, and joint pain are some other ones that come up in this category for me. And then the stress tolerance or critical mineral corticoid system is another one that I really like to address. And some of these questions would have to do with water retention, frequency of urination, mood changes. And then on the perceived stress side of things, we always associate stress with, how much load we're putting on that athlete in terms of training. But, the coach-athlete relationship plays a huge role here. The athlete-athlete relationship plays a huge role here. So many other stress tolerance impacts play out, and we'll get a little bit more into these as we go, but it's not just, how much you're training. So when we look at this neurocircadian rhythm aspect of stress tolerance, we think about the anxiety, stress, cortisol loop. So disrupted sleep patterns, emotional stress, and poor eating habits all going to play into neurodegenerative conditions. We'll start to see that impact on cortisol. And then what is the translation of that? So for an athlete, we start to see attention and focus issues, learning and recall issues, short-term memory deficits, and word finding. If we allow this to go on long enough, we're really going to start to see neurodegenerative conditions. So too much cortisol to the athlete for a long period of time will result in brain changes. And I think on top of the risk for female athletes with head trauma, we really have to consider this too. When we look at that cortisol melatonin curve, this is obviously another huge impact of stress tolerance on an athlete. We want cortisol to, peak throughout the day and start to come back down, and then melatonin just kind of peak throughout the evening time. Cortisol will drive melatonin down any chance it gets. So if we start to see that, cortisol is overriding these things, or the athlete is extremely stressed throughout the day, we have to do something about it. When we talk about sex hormones and the female athlete, when we do a lot of this research on female athletics and if we should make any modifications, it doesn't seem to be the actual bleed itself that is impacting athletes. It's all of the symptoms that go along with it. So inherently, a period is not a dysfunctional thing. It's a dysfunctional period that is a dysfunctional thing. When we look at what's going on, there's a lot of, key things that we could start to implement that would make a game changer for a lot of these athletes and allow the period not to be such a dysfunctional aspect of sport. It's more so, these symptoms that are coming up that we have to address. So when we think about cramps, magnesium is a great intervention there. Psoas release, so getting some soft tissue work done or acupuncture work done. We really want to consider to the degree of cramps that the athlete is experiencing would be gynaecological conditions. So are we looking at endometriosis or polycystic ovarian syndrome, fibroid cyst, or adenomyosis? And a lot of people listening here are probably not in the realm to diagnose this, but certainly conversations that you can start to have with the athlete for them to bring it up to their medical professionals. If the cramps seem to be very, very strong and very, very hard, we have to ask some of these questions or we're kind of doing a disservice to that athlete. Heavy flow is another big one. So that's, what we're looking at in terms of iron status, again, considering those gynecological conditions. And as we note, some recommendations for pre-period PMS support would be blood thinners, which could make this a lot worse. Cravings are another one, especially if it's weight class athlete. We have to recognize that this is a thing and make sure we meet the criteria or make sure we're accounting for this when we're leading up to a body composition goal or change. When we think about cravings too, it has a lot to do with serotonin production. So is there simple things that we could do to meet those serotonin needs without increasing calories if that would be detrimental to success of the athlete? Fatigue is another huge one. So there's a lot of nutrient deficiencies that we should consider here. Again, that stress tolerance load is going to be a big piece of things, and fuel intake. So again, making sure the athlete is eating enough food is going to have a huge impact on how tired they are at that time. Mood changes is another big one. If you're not feeling it, it's going to be really hard to perform at that time. We're seeing a huge drop in serotonin and some of the other neurotransmitters directly before the period as estrogen and progesterone start to go down. So is there other things that we can do to help support mood at that time? Probably. If the mood changes are extremely severe and you notice a marked difference in your athlete, could we be looking at premenstrual dysphoric disorder as well? So that's an extreme symptom presentation of PMS with a lot of anxiety, depression. There's a full diagnostic criteria that we could start to look at. Again, maybe not in your wheelhouse to go through all of this stuff, but certainly give the athlete some education and recommendations to talk to their medical professional about. With gut stuff, again, fluid retention, that's going to be so detrimental, especially if you're looking to meet a weight-based sport need. And then, you know, diarrhea, we're going to see increased inflammation at that time. So what do we have available to us to mitigate some of the prostaglandin release at that time? Again, all of this to say the sex hormones impact on PMS is the impact on performance, not necessarily the fact that we have a period itself. So careful for catch-alls too. So as I had mentioned, there's so much stuff social media wise now about female athletes and what we have to do throughout the cycle to optimize performance. And I think there's such benefit to this because it's starting to open up doors, it's starting to open up education opportunities, and it's starting to really give athletes autonomy over trying some stuff and seeing if it works for their body. But what we want to think about is really the physiology that's happening here. So if we think about aspirin as a blood thinner, if we're looking at a heavy bleeder already, could this impact things and lower iron even more, or ferritin stores even more for that athlete? Magnesium wise, there's different types and absorption really depends on the right type. So again, catch-alls of magnesium, we have to pick the right one for the athlete and know which ones to recommend and support with. With omega-3, as we know, there's so many benefits to omega-3, but dosage and quality are hugely important to that. Timing is another huge thing for omega-3 support as well. If we're not trying to recover the athlete and really trying to get some sort of adaptation response, could we be mitigating that with omega-3 supplementation? So digestion and inflammation, again, are another huge aspect of what presents for female athletics. And you'll probably note as we go through these, it's not a huge differentiation between the male and female population aside from the sex hormone impact, but more so like this is what we're starting to see and this is what we're trying to treat, not necessarily the fact that we're working with female athletes in general. It always comes back to the individual who's sitting in front of you and what they're presenting with. So all of this is just to give you highlights of things that I see quite often and some resources available to you to help ask the right questions and support this athlete. When we think about the stress response or stress tolerance load for a female athlete and athletes in general, we're looking at as if their perceived stress, actual stress is ending up into a fight or flight response. If we are seeing a fight or flight response that they're very taxed or stress tolerance bucket is full, what we tend to see is either a lack of blood flow to the digestive system or something that almost looks like a dumping syndrome. So as soon as they relax for a second, they have diarrhea. Or if they're pre-competition or in and around competition, everything gets held onto because there's not enough blood flow to that digestive system. So these physiological changes long-term can lead to microbiome changes. In the short term, we have what's called intestinal permeability, or what I would like to describe as if there's too much stress to the system, we're not getting enough blood flow there. Not enough blood flow to the system usually looks like backup. Backup to the system looks like inflammation. So things start leaking out of your digestive system systemically, and that's certainly going to cause, you know, brain dysfunction, skin issues, joint pain, all that sort of stuff that can present for these athletes. So the mineral glucocorticoid system is a huge one for female athletes, especially if we start to see massive hormonal fluctuations just before that period. We do see fluid retention, and if we had an additional stress response or high sympathetic driven or fight or flight athlete around that period time, plus fluid retention, plus bloating, you could just imagine how that's going to play out for a weight-based sport athlete. So there's so much to go into here, but all I could really, you know, summarize here is increased cortisol looks like fluid retention and decreased cortisol overall looks like fluid loss. So we start to see that we're trying to make weight for an athlete. If the body composition isn't changing, if X, Y, and Z happens with this female athlete, stress tolerance is a huge thing to consider on top of hormonal cascades. So oftentimes we want to blame progesterone for this, and there's certainly a role there. But if we really bring it back, like what could be driving some of these sex hormones, and probably the stress tolerance system has a role here. So all of this to say, this is scientifically or physiologically what's happening. In a regular working system, the hypothalamus in your brain releases gonadotropin releasing hormone. This guy goes down to your pituitary to release FSH and LH. FSH and LH are going to your reproductive organs to release an appropriate amount of estrogen, progesterone, and testosterone. When we have a highly stressed state, and again, that could be perceived or actual stress, and that could look like training schedule, that could look like unmet fueling requirements, it could look like poor sleeping patterns, coach-teammate relationships, outside relationships, all of these types of things start to play into that perceived or actual stress response. Gonadotropin inhibiting hormone will start to be released. And that actually inhibits this cascade. So it's the downregulation of cortisol, the downregulation of our inherent stress response. When I talk about the stress response, it's actually a really good thing for the athlete. It's a really good thing for an individual. It's what gets us up in the morning. It helps regulate blood sugar control. So when we start to see dysfunction in this system because of the stress tolerance limit being too much, that's when we start to see dysfunction. And down the road in the HPA, hypothalamic pituitary adrenal, and then hypothalamic pituitary gonadal axis, we start to see that impact on sex hormones. So all of this to say, most times I don't go directly to sex hormones as the problem. Estrogen is not always the problem. Progesterone is not always the problem for these athletes. Usually it's a derivative response from the adrenal glands or their stress tolerance load or their perceived anxiety load throughout the season or throughout training programs. So this is some stuff that I really want us to get a handle on, because if we just jump to something that will get rid of more estrogen in a female athlete system, we miss the boat on the actual root of the problem here. Melatonin shuts off GnIH as well. So if we're not functionally producing the right hormones at sleep, or if we're not getting an appropriate amount of sleep, then we are actually seeing a dysfunctional pathway here as well. Here's a larger and broader context to some of these hypothalamic pituitary, adrenal, gonadal, and thyroid axis. So unfortunately on the female athlete side, we are seeing a lot of thyroid conditions as well, and in guys too, but this is how it all interconnects. And the root of a lot of this is perceived or actual stress to the body. So there's so many things that we have in our wheelhouse to catch this first, to be a support network for these athletes, and start asking the right questions to see if some of these hormones are being impacted and where in this cascade we're starting to see the impact originate from. So again, don't jump right to sex hormones. There's so many things that we have to consider before that, that are probably more root cause approach to what we're seeing the athlete present with. So puberty is a pretty pivotal time in a female athlete's life. There's a lot of changes that are happening that, we're losing a lot of athletes too. Most females quit between that 12 and 15 age range. And I believe if we educated more on this, and if they knew what was coming down the line, and if they knew what their bodies were doing, we can mitigate a lot of this dropout. So what we want to kind of think about here is the Q angle change, the brain, and some systemic symptoms. With this Q angle change, we're basically measuring the hip to the knee. And if you think about it, previous to this, a male and female body are fairly comparable, but with the changes that happen at puberty, we're seeing hips widen. And that gap or that change is really making that Q angle larger, which actually puts a female at increased risk for knee injuries. These change in mechanics too can make you feel a little bit Bambi. So if you were, keeping up with the guys for your entire career up until puberty, and then you have this whole limb change that's happening and balance issues that are changing and instability that comes along with this, then you may inherently feel that, you're not able to compete anymore, where it's actually just a physiological change that we could account for and support for these athletes. So, for strength coaches who are listening and really anyone that's listening, considerations for strength training based around this. How do we support the knee? How do we support all of these physiological changes that we know are happening to protect that athlete and to make them feel less out of their element at this time? Estrogen also, really increases at this time. So we do know with this estrogen influx, it seems to be that female athletes are at increased risk of ligament injury. And that's just starting to come out in some of the sports specific literature too. So we see, with female athletes in soccer, how many ACL ruptures we're starting to see, or are starting to notice, I guess we should say. We've always seen them, but to make a correlation and causative reason, perhaps this is what we're talking about here. So again, kind of, who cares that it's happening? We don't want to stop estrogen production. We just want to protect the athlete. So with all of your back wisdom on how we would support a knee joint with the potential for ACL rupture, how do we change programming for these young female athletes to protect them long term and to build that muscular structure around the knee to put them at less risk for some of these potentials that we're starting to see? Brain changes are pretty big too. So, anxiety, depression wise, we're seeing, a huge flux of females over males at that puberty timeframe. So what do we do about this as practitioners? A, our job is awareness and to check in on some of these things. B is what resources do we have available to support these athletes? And this is by no means to negate that male athletes aren't experiencing this too, but ratios just look higher in females. So how do we check this? How do we support these athletes and make sure we're doing everything that we can to mitigate some of this as well? Complex strategy is an interesting one. So some of the literature that's coming out seems to show that in complex strategy, females through puberty have a huge capacity here. So maybe there's a differentiation here we could start to pull in terms of executive planning with exercises or executive function within an exercise. The capacity for very high adaptation and understanding of their body, and also complex strategy in terms of drills and movement patterns is very high for females. So definitely don't be afraid to push them at this time. It seems as well that female athletes have an altruistic and moral compass, and that seems to differentiate pretty substantially at puberty. So when we think about this as a coach, as a practitioner, as a support system for young female athletes, what do we do about this? And I think oftentimes when we think about that young female athlete, and perhaps I'm pulling on past experience as well, that, our job was to compete with the males for so long. You have to push harder, you have to show up more, you have to be above and beyond everything that the male counterpart is doing to show worth and to show value. So if altruistic and moral compasses are quite strong in that female athlete, what do we have to do to support these athletes to avoid the burnout spectrum of all of the symptoms that I had mentioned earlier? How do we protect them against this feeling of bigger, stronger, faster, always having to prove themselves? Because unfortunately that does end up in a vicious cycle of under recovery oftentimes, especially if that is the perceived stress response that they start to adopt throughout their athletic career. Then there's some systemic changes that happen. So, with hormones, we start to see an increase in belly fat, especially around the midsection and breast tissue. This is pretty detrimental to a female psyche at this time, but I believe if we warned them it's coming and if we prepped them for the change, then we could be really, really supportive at this time. And what I think about in this context would be, unfortunately, throughout society, the main go-to for this for athletes or non-athletes is to eat less and train harder. Whereas if we knew this was coming, gave really great recommendations and understanding and compassion around these changes, I think we would see less dropout in sport, and I would think we would see less under recovery based on all of those above mentioned aspects. We see lower hemoglobin too. So that increase in bleeding and being an athlete can cause low iron. Iron, B12, and vitamin D status are just things we should not even think about. We should be checking these no matter what in all female athletes. It's just our due diligence. And then when we think about functional ranges for some of these values, like a ferritin marker it has to be well within the range of conventional medicine. And to be honest, like anything below 35, we could see dysfunction. So what I really like to consider here is not only are they in the range of conventional standards, but they're well within that range to make sure we're not seeing any symptomology based on that. Female bones get longer and then they fill out. So that actually puts us at an increased fracture risk. And on top of that, oftentimes we see nutrient deficits and not consuming enough food. So with all of this, we're putting that athlete at a huge risk of fracture. So again, education here and understanding and making sure we're supporting these athletes is what we're looking at. Heart and lungs, so boys' hearts and lungs capacity are larger. So comparison of abilities is tough here. So especially if these athletes have played with guys their entire career up until puberty, and then all of these shifts start to happen, you could imagine the mental toll that could start to take, where they feel inherently like they're not being able to meet standards or not being able to do what they used to do. Whereas it's just simply an education point to say what's happening to these athletes so we can prepare for it and understand these physiological changes. Body odor and skin are two other massive components here. And this can be a huge blow to confidence. And we also want to make sure that we're supporting athletes with whatever they're presenting with at this puberty time frame, because we want to stop losing athletes at this time frame. This is the key time where female athletes start to drop out. So if we educated and supported and had resources available, could we mitigate a lot of this as well? So the cycle, there's so many great explanations of the cycle. I think we've all heard it and know with some sort of certainty what's going on there. So what I like to highlight here is what are averages? So what are we actually looking at, and what would dysfunction be outside of these averages? Every research paper that we have is based on a 28-day cycle. So most times the athlete sitting in front of you will not be on a 28-day cycle, or will be on birth control, which would skew that cycle normalities as well. What we're looking at is 5 to 80 mils of blood. So you know what, go home and take a good idea of what that could look like, or explain in tampon use, or explain in pad use what that could look like. If it's much beyond that, or if they're changing pads every 2 hours that are fully saturated, or tampons fully saturated and using Super Plus, then we have a conversation. You have to get that supported, because we're putting iron at risk, we're putting ferritin stores at risk, and we're putting the athlete at risk too. 4 to 8 day bleed is pretty average. Anything much more than that, again, we're looking at iron stores, how much blood loss we're starting to see, and fatigue issues for that athlete. Less than 4.2, we could be looking at a hormonal deficiency or something happening there. So certainly something to check in on. Doesn't necessarily mean abnormal, just things that we want to look out for. And then, as I said, so every research paper so far has been based on 28 days of cycle, whereas norms are 24 to 38, and there's a lot of fluctuation in between that. So we just want to make sure that we have a good idea of what some of these averages are, and how we ask the questions is important, and how we refer them is important in terms of what they're presenting with. This is one of maybe a pet peeve that I start to see on social media quite often, is like, estrogen does this and progesterone does this. So sure, there's things we could consider on the individual hormone basis, but what I really want to highlight here is none of these are working in independence of each other. So if estrogen is a little bit anabolic and progesterone is a little bit catabolic, then they're balancing each other out. There's no point that progesterone is being produced without some sort of estrogen as well. So when we see all of these posts saying like progesterone is blank at this time, we really want to think about the physiology here. They're never independent of each other. They're always working together. And usually if one does one thing, the other does the opposite. So we really want to make sure that we're not putting too much value in the highs and lows of these things, as the body loves homeostasis. So everything that is doing is going to try to keep everything in balance as much as possible. So this is a big one for weight sport athletes, or weight-based sports. When we look at one consideration for that female cycle, early in that luteal phase, we start to see progesterone rise, and that binds to aldosterone receptors, and it actually binds stronger than aldosterone. So when aldosterone binds, we start to see water retention, and the opposite when progesterone binds. So if we see some sort of progesterone dysfunction, if we see this athlete present with a lot of bloating, a lot of fluid retention, and we have to compensate for that through weight cutting sports or trying to meet a certain body composition goal, then we have to be aware that this is happening. So in summary, to say that if this is happening, how do we protect the athlete from it? How do we make sure that it's not an inherent hormone dysfunction here. It's more so we have to know that it's happening, and we have to compensate for that when we're trying to meet the weight requirements, or when we're trying to design a program for this athlete to make sure that they're going to get there. We have to account for this. And the only way we can account for it is to measure it and to know that it's happening. So, you know, getting 3 to 6 month averages of weight fluctuations throughout the month of these athletes prior to trying to hit a certain target would be really helpful to know what their body is doing and to be able to account for any of these changes that come up. So with all of the research coming out, which I'm so excited about, it's so fun to, you know, browse through all the literature and see what suggestions are being suggested to mass populations. But I want you to like take all of this information ever so slightly with a physiological brain and an understanding of the individual athlete sitting in front of you. When we look at the research coming out, what can we actually say about it? So research is quite limited and very small sample sizes. There are some larger studies, you know, starting to be conducted, but this is new. We're starting to get money filtered towards female athletics, and so all of the stuff that's coming out is, you know, brand new science, and it has to be validated too. So we have to have repeat studies to say the same thing. Not all papers are consistent with measurement techniques to determine where an athlete is in their cycle. So some use blood, some use urine, some use patient reporting. And all of these will inhibit our ability to cross-reference those research papers, because blood analysis is different than urine analysis, and patient reporting is really tough to go off of because a lot of athletes don't know if they're ovulating. They don't know where they're at in their cycle, and a lot of them just know the bleed time, but outside of that, it's hard to gauge anything else from that. So there's a lot of conflicting research out there too. With a lot of new stuff, of course, there's going to be conflicting research. There's a lot of short study duration. So when we look at sex hormones, we need about 3 months on average to get a really good idea of what's happening. And unfortunately, a 3 to 6 month research timeframe is really expensive to do. So we're not getting full ideas or full pictures of that full hormonal cycle or full hormonal turnover for some of these vast recommendations that we're starting to see. Overall, some research papers highlight maybe a decreased performance in that early follicular phase. So right off the bat, what do we do about this information? If you ever told an athlete that, would they not inherently feel a little bit less their best at that time? So wording and terminology becomes really important when we're trying to translate some of the information that we see in this research too. Muscle and tendon research, we need a lot more of it. We clearly see something happening at that puberty time, and we're really starting to see the amount of ACL or ligament and tendon issues in female athletes. But to what extent the causative factor of that is, more research is needed, and what recommendations for standardized training we make based on that, again, we need more information. We have to take it case by case and athlete by athlete. So whatever the athlete is saying to you, sitting in front of you, we can't make general recommendations. We have to go after this with the individualistic approach of whatever the athlete is presenting with in front of you. So right now we don't have really great general recommendations on birth control. Each birth control is very different in function and how it presents and what it does to the body. So it's really hard to cross-standardize a lot of these recommendations, even though social media is kind of blasting them out as if this is what you have to do throughout the cycle and at different times of the cycle. So I added this in for you guys to understand what's actually happening on the research front. That doesn't mean I'm not absolutely so excited to see some of this come out, but it's more so just we're not there yet. We can't make these general recommendations yet. One thing I really like to highlight with a lot of female athletes is polycystic ovarian syndrome versus adrenal polycystic ovarian syndrome. And I don't think adrenal polycystic ovarian syndrome gives enough justice to what we're actually looking at here. And the reason I included this slide is because I see it so often that I think people should be aware of it. So when we look at classic polycystic ovarian syndrome, and there are a few different types, but we see you know, ovulation issues or no ovulation. We see hyperandrogenism like hirsutism or abnormal hair growth, receding hair, male pattern hair loss essentially. And we see cysts on the ovaries when we do ultrasound. With adrenal type of PCOS, we can have abnormal hair growth. We can have you know, androgenism presentation or hyperandrogenism presentation, like acne around the jawline, like male pattern features. But the root cause of this is what we really want to address here. So this all comes back to the stress tolerance aspect of things. Did we run that athlete into the ground? Did we completely under recover that athlete? And now it's an adrenal or stress driven polycystic ovarian syndrome type presentation that we're starting to look at. And if we don't get to the root cause and we treated it like classic PCOS, then we miss the boat for that athlete. You know, starting to manipulate diet or starting to suggest things like inositol or blood sugar regulation in an adrenal type presentation is not going to do the athlete justice. We really want to consider that this is probably driven by stress tolerance or perceived stress tolerance, and that's the root of this, and this is how we have to support that athlete. So I really like to highlight that one because it's something I see so consistently. There are differences in blood work that we would see with the adrenal PCOS versus regular PCOS. And again, with a female athlete, sometimes and in some instances, we have a higher testosterone percentage anyway, and that's perhaps what drove them into sports, or that performance base is based on a higher testosterone level anyway. So again, really analyzing the data and really analyzing the athlete in front of you is super important here. When we look at the nutrition aspect of some, female-based presentations, there are some general recommendations that we start to see, and you can kind of take this slide and go with it, and it's not a horrible way to go after supporting a female athlete, but really, like, let's consider what this is saying. So in that follicular phase, we see carbohydrate oxidation, we see intense exercise should be fueled, but like, when would that not be the case for a female athlete? Follicular phase, check iron stores. When would we not check iron stores for a female athlete? So the summary of this 2021 research study is just stuff that we should be doing no matter what. In that follicular phase, we see a decrease in protein oxidation, a decrease in fat oxidation, and glycogen stores. We could consider, branched chain amino acids, or I would prefer essential amino acids. But if the athlete was hitting protein targets like they should be throughout their entire cycle, we kind of mitigate some of the need for all of this anyway. And when we see a lot of athletes presenting, no one's hitting protein targets, no one's hitting overall caloric target needs. So before we put the horse before the cart, I think it's really important to get baselines covered before we get into the nitty-gritty of cycle-based nutrition or cycle-based training. In the luteal phase, there's an increase in fat oxidation, protein oxidation, and resting energy expenditure. So this one may be a little bit interesting, and the athlete sitting in front of you will describe this as, if they're hungrier before their period, perhaps they need a little bit more fuel before their period. It's a huge metabolic process, having a period and shutting that endometrial lining. So if the athlete is saying that they're hungry, could we just, accommodate that for that a little bit more? Could we bump up calories a little bit more at that time to support them, especially if they're feeling additionally fatigued? And in saying that, carb-based seem to help with those serotonin pathways, which could be causing some of their symptoms or PMS type of symptoms that we're seeing. So, a little bit more carbs at that time, or a little bit more calories in general, might be really supportive. And obviously this is dependent on what the athlete's goals are, but if we account for it, if we fuel them for it, and it's probably, a couple of days not going to make that much of a difference in terms of their overall caloric target and needs, and it might just make them feel a lot better and be able to perform a lot better at that time. So consider that for sure. And then luteal phase, we see decreased carb oxidation, but again, coming back to those foundations of fueling the athlete appropriately is the foundation of all of this. So, inferring too much from this is a disservice to the athlete in front of you. Always make sure we're hitting protein targets, always make sure we're hitting overall caloric targets, and making sure we're hitting fat targets. So we definitely have enough fuel to fuel making a lot of these hormones as well. Carbs too, they've gotten such a negative connotation in these past couple of years. So I often see a lot of athletes avoid eating them or trying to minimize how much they're eating. We want to be, a wealth of education on this. And if you're looking for performance goals, it probably certainly doesn't look like, removing carbs from your diet. So, being a foundation of education for all of this is the most important part. And before we say, throughout your cycle, you have to focus on, hitting these throughout certain time phases of your cycle, it's way more important that overall needs are met first. So for nutrition, my recommendations, hit caloric needs of the individual athlete sitting in front of you, then hit their protein needs, and probably 1 and 2 would be hand in hand of importance. And then with tracking, we can start to delineate what we're going to do with that athlete. So once they're great at hitting calories, once they're great at hitting protein, once performance is well off to a great start, maybe then we can start to tailor in a couple of things based on some of the research that we start to see. So if this athlete is showing up with disordered eating patterns, we're going back to square one again. And some of these recommendations can elicit disordered eating patterns as well. So you really have to look at the athlete sitting in front of you. Are they equipped to manage this, fine tuning of nutrition, or should we just stick to the basics and they're gonna, do great with that too? So peri and perimenopausal and menopausal athletes, this is a whole other ball game, and probably could do a full presentation on this as well. For reference, menopause is 1 full year without a period. So that's the diagnostic criteria for it. And I think even educating some of your patients and athletes on this is really helpful. So when do we know that we're in menopause? There's so much coming out right now about the perimenopausal state, but for individuals to understand that menopause is just 1 full year without a period. And there's so many changes at this time that will certainly impact performance. I'm going to highlight a few here, but certainly more research is needed in this area. But again, treating the individual in front of you is the most important thing we could do here. So the body changes we start to see, sleep is a huge one. So melatonin declines as we age, GABA, serotonin change with hormonal fluctuations. So as estrogen and progesterone starts to go down, could we start to see, GABA or serotogenic changes there? And with progesterone going down too, we start to see maybe anxiety start to creep up. So if you have age ranges of athletes in that perimenopausal or menopausal timeframe, and perimenopause can start 10 years before menopause does. So if you have that 40, 41-year-old athlete coming in saying they just can't perform anymore, or they can't do what they used to do, maybe this is time to start to consider, is hormones playing a role in this? So hot flashes, electrolyte considerations are absolutely massive here, and decreased estrogen can elicit norepinephrine, which can make the body feel like it is having a hot flash. What do we have available to us? Like, what are the calming techniques the athlete can have? What is the overall stress tolerance load where we can mitigate how many hot flashes they're experiencing in general, and then keeping them hydrated so they're not losing sweat rate based on that either. Weight gain, so insulin changes with, there's a lot of metabolic changes that happen with perimenopause and menopause. So what we want to consider here, what we want to consider here is what that athlete needs, what we're starting to see, and what our goals are with that athlete too. Are we trying to get to a point where we're looking at a weight loss type of thing or body composition change? And if so, what do we have to do for that individual athlete? If we know they're becoming more insulin resistant, if we know that protein needs are drastically increasing at this time, could we just make the impacts needed for that? Could we, maybe time carbohydrates a little bit better for that athlete and increase protein needs to mitigate weight changes at that time? Anxiety, brain fog, and heart palpitations. So serotonin, GABA changes, as I had mentioned, and changes with the decline in estrogen and progesterone. Usually we start to see sleep issues at this time. Increased adrenaline is a big one, and decreased B vitamins and magnesium storage. So of course, these two are going to deplete as we age as well. Could we make up for a lot of this with fueling them appropriately? Certainly. And then there's some supplements that we have access to that could be really supportive for some of these presentation of symptoms as well. A lot of perimenopausal athletes complain of how much increased flow that they're experiencing, a lot of leaking, a lot of standing up and gushing of blood, a lot of impacts to performance and energy levels based on this. So what's happening as progesterone starts to decline, we're getting unopposed estrogen. So that endometrial lining can grow very, very substantially and very, very thick, which looks like a lot more blood coming out on a monthly basis. Here we also want to assess for fibroids, polyps, cysts, any sort of gynecological condition that could be presenting. And then the HPA-G axis is going to have a huge impact on how quickly those hormones start to decline as well. So a lot of perimenopausal symptoms could be driven by this perceived or actual stress response, which would be impacting those sex hormones down the road. So if we get to the root cause of these stressors and help support these stressors or athletic tolerance load, then we can make a huge difference on some of these perimenopausal changes. And then pain, inflammation, and migraines, with the change in hormones, we can see increase in dysfunction here. So, asking questions about joint pain as estrogen declines, it is what keeps our joints lubricated. So what options does that athlete have available to them, like collagen and other supports, to make sure their joints are functioning as well as possible? As estrogen declines, we also see a huge impact on that histamine response, which could be, impacting migraines. It could be impacting food sensitivities, digestion issues. So in theory, there's some things that we can definitely support here and definitely make the athlete feel better, but we just have to know how they're presenting and what they're doing in front of us. So testing wise, I mean, if we're sitting in front of an athlete, certainly take the case, but we need to be looking at full thyroid panels. We need to know what the brain is doing. And for a lot of female hormones, we want to measure either on day 19 to 23 of the cycle or day 3 of the cycle to get a really good idea of what we're looking at here. So estrogen day 3 would be really important to measure at that time, whereas progesterone, we want to see it at its peak. So day 19 to 23 for accurate measurements. DHEA is the precursor to testosterone. So, this is really going to help us check for adrenal function and what we could be looking at there. Ferritin, B12 are huge markers that we need to be addressing for these female athletes. HSCRP is a marker of inflammation. Why would this athlete be so inflamed, or what potentially could be going on? We know the rates of autoimmune conditions for females is exponentially higher than males, so could we be catching something there if we're doing the right measurements? And then 4-point cortisol test is really important, because if we just measure cortisol first thing in the morning at 8 a.m., we might miss this stress tolerance load, or might see that there is a huge dysfunctional cortisol rhythm throughout the day. But if we only have one marker, we're not going to get the full picture of what potentially could be going on. So for all male coaches out there, these are just 3 tips that I have. I guess the first one is male, female alike and practitioner alike. How do we modify training? We don't really know yet. So definitely do your research. We'll keep looking into all of these things. No vast generalizations or recommendations yet based on cycle training. How do I talk about this? So to you and your athletes' level of comfort, and be transparent with those conversations. Are you okay if I ask these questions? Could we start having this conversation, because I really think we can improve performance if we have a better idea of what's happening internally with your body, and really from a place of learning. So just because you've read, a great book on the cycle and know a lot about it, that female sitting in front of you knows her body better than anyone will ever know it. So, asking questions and being inquisitive versus being like, I read that this is what's happening, so this is what's happening to you. I think is really important. Again, that's female and male coach considerations both. And then know your stuff. So it's really important to stay up to date on this stuff. It's really important to ask a lot of questions and read as much as you can. And for female athletes, I know we're not looking for sympathy or a break. We're looking for understanding and modifications based on how we're presenting. So sometimes it's a disservice to say like, oh, just take a rest. I know, you're bleeding heavy or something like that. No, they're looking for options. They're looking for ways to push beyond those limits, and really understanding their physiology and how to modify for performance gains too. So usual asks, as far as we know, only change programming based on the individual in front of you. Like there's nothing else, and you guys are well equipped of understanding, the strength and conditioning side of things, or the patient presentation of things. So you don't modify because they have a cycle. You modify because they're complaining of something, or they have symptoms that meet some sort of criteria that we should look further into, and get them to track. So every female athlete should be tracking their cycle as much as possible. There's tracking specific, like Wild AI or Fitter Women are both athlete specific. Wild AI has a coach option too, where you can start to see some of the background information. So instead of having the conversation every month, you can just go in and check and see, if this is impacting performance for them. And this athlete has to be ready at all time. We don't always get to pick competition time. So, saying that we should rest during certain phases of the cycle is an injustice to performance metrics for that athlete. We have to be ready when we need to be ready. So keeping that as the foundation of considerations for a lot of these athletes. So sleep considerations is a huge question. I get asked about it all of the time. If we do see PMS time sleep considerations, perhaps, re-emphasizing protein targets if they're not already hitting them, or adding in essential amino acids might be a key one there to make sure the brain is getting what it needs to reduce that serotonin drop. And then pain is another huge one. So what do we have to do to mitigate their pain? You know, repetitive NSAID use is going to be detrimental long term. So what other resources do we have available to relax their muscles, like magnesium, or reduce inflammation like fish oil? And again, dosage, timing, and type is so important there. If an athlete responds that they've lost their period, we really have to figure out what's going on there. This is not something to just let go after, you know, till the off season. We want to assess, because it gives us long-term data that something is going wrong in their body. You know, could we go back to the HPA axis and find dysfunction there, or is it truly, you know, a hormonal abnormality or that relative energy deficiency in sport that we're starting to see that's creating this problem? Strength training, your athlete will know so much about their body. We can tailor PRs around some sort of time if the athlete doesn't have performance metrics that they have to hit throughout their entire cycle. There's some interesting stuff that we can gain if we start to track some of these things. But again, if you have to be ready at any point throughout the season, it doesn't really help much to know that you're the strongest, you know, just before you have your period or while you're on your period. So terminology and how we speak to these athletes and what we put in their heads is extremely important too in terms of performance gains long term. If you tell an athlete that they're weaker around period time, they're inherently going to feel weaker around that time. Or if you tell them they're super strong during, you know, the luteal phase and competition doesn't fall in the luteal phase, they'll feel like they missed a window of opportunity of performance that they might not be able to meet at that time. So, you know, being so intentional with how we phrase this and how we present this is really, really, really important. So coming back to this case study, interestingly enough, like we had so many axes of dysfunction here with this athlete, and working with the UFC, we've developed kind of like a criteria protocol to see where in the stress tolerance load we see dysfunction. And for this athlete, we saw sex hormone dysfunction, gut dysfunction, relative energy deficiency, of course, because of when we were timing things, metabolic dysfunction and sleep dysfunction. So, you know, what we did was really treat the symptoms that she was experiencing, really treated the individual, reset her gut health. We gave everything in terms of magnesium, sleep support aids that we had available to us that are certified for sport, and then did a huge education in terms of perceived stress tolerance with this athlete. And it turns out there was a lot of relationship things that we had to address, and there was a lot of perceived stress from coaching or demands that were put on her body that, you know, she was creating in her own mind. So, you know, sending her to health or a sports psych was really important in this case as well. So after our timeline with her, around 3 to 6 months was when we first checked in. We didn't get a period back yet, but body composition started to do what we wanted it to do in terms of moving in the right direction. Overall, she felt a lot better and was feeling ready to start to get in the game again. And then so this case study was a while back, but it probably took around 6 to 9 months to get her period back. Initially a little bit of a spotting, and then we got a full-on one probably 2 months after that. So again, how important it is. Maybe the refeed was a pivotal part of this, but there were so many other aspects that we had to do to get that full body back and that full metabolic process back. So, you know, just considering how much the athlete is eating is one part of things, but there's so much that goes into the perceived stress tolerance load and the actual stress tolerance load of an athlete. So my summation in all presentations is like our bodies are capable of the most amazing things, and just because there's a cycle involved doesn't mean it impacts anything. We just have to recover our bodies appropriately. So understanding, you know, what could be going on and asking the right questions and treating the individual in front of you is the foundation for considerations for female athletes. And knowing that perceived stress or actual stress tolerance is probably a huge driver of a lot of these sex hormone issues to begin with is really important to note and really important to consider when you're working with athletes. Thanks so much.
Thank you. So we do have one question that popped up, guys who are watching. If you have any questions, please post them and we can get some answers for you. So, oh, wait, just deleted the other one. I'm new to GoToWebinar. I'm trying to figure it out. To clarify, Dr. Kokes, you said estrogen declines in peri and menopause. Mm-hmm. Histamine levels can go up. Do we know why that is?
the histamine cascade has so much dependent on estrogen as well, and we see this in males and females. So the issue is like estrogen is mitigating the histamine response often. So as with perimenopause and into menopause, we're seeing a sharp decrease in estrogen and progesterone, just as physiologically what's happening. We're getting less regulation over that histamine, so it can like blow up more, I guess would be the best way or easiest way to describe it.
Okay. My understanding is the uptick in ACL injuries is potentially more related to glyphosate. Glyphosate mimics glycine and attaches at that receptor site on the cell and makes connective tissue brittle. Have you seen that research also?
I have, yeah, there's so much opportunity out there for what potentially could be going on and how we then translate that to mass populations. So that certainly could be playing a role in it. When we look at, some of the research, estrogen does seem to have some sort of impact, but what impact of estrogen? So yeah, if it is a driver of ligament laxity, if it is, all of these more in-depth physiological processes, that is the actual issue, then that's what we want to treat, right? Not the actual estrogen themselves. So, further understanding of this and overall kind of who cares, how do we protect these knee joints or how do we protect these female athletes is probably the summation of what we're looking for. And if that is the physiological basis for why this is happening, does it change drastically supplementation wise what we're going to do for these athletes? Maybe, to build up those stores and give a little bit more additional support there for sure. So estrogen is a generalization. Now we're trying to like go in through the weeds and figure out what about this actual change or why female athletes may be more susceptible to these injuries.
Okay, this sort of leads into the next question. Do you have a female athlete supplement stack you think most females do good on?
Yes and no. So again, very dependent on the individual, and I think like they all range. So depending on what that athlete is presenting with sitting in front of me, I know they do really well on magnesium bisglycinate or threonate, depending on, if there's any anxious or brain stuff going along with it. That's usually one that I incorporate no matter what. A lot of athletes, a lot of female athletes that I see are low in iron. So of course we want to replace some of those. And then again, through PMS time, what are they presenting with? And sometimes we're working a little bit with our hands tied behind our back because some of those big ones that we know in a general sense, like Vitex, that could actually impact sex hormones, are not NSF for sports certified. So what else could we do? How do we work around to support that athlete with what they're presenting with? And oftentimes it can come back to nutrition and some really basic supplementation that can override more of the perceived or actual stress response versus trying to go after sex hormones.
Okay, thank you. Any last minute questions, everyone, before we wrap up? Oh, we got one in. We got two in. Okay. Are these tests you generally run on female athletes, such as Dutch or other hormone tests? Are there tests, not these, but are there tests you generally run on female athletes, such as Dutch or other hormone tests?
Yeah, I like blood markers for a lot of these things. With cortisol, it's hard to do a blood marker 4 points throughout the day. So salivary or urine metabolites of cortisol is a good representation because we get a visual of what's happening to cortisol throughout the day. For sex hormones, the trickiest part with blood markers is the ranges are massive. So understanding an athletic range of a lot of these is really important. And then it's really hard. I know specifically here in Nova Scotia to get blood work done on a certain day of your cycle. So unfortunately, sometimes we have to turn to alternatives that may not be as accurate or as diagnostic, but it's our only resource and we confer a lot of information from the data that we get. So as long as practitioners understand that it's not diagnostic and there's some maybe translation of, if we're looking at urine metabolites, what does that actually mean with what's being used in the body versus seeing it on blood work, we'll see what's circulating in there, So I think I use some of these for sheer reason that we don't have access to other options and the convenience of it all, especially an in-sport athlete. We have to look at, timelines and timeframes and really supporting them with where they're at currently.
Mm-hmm. which nutrition tracker do you recommend or like? Do you or do athletes track? Do you track or do your athletes track?
Yeah, I've tracked on and off for tracking apps. There's so many out there, and to be honest, like, I mean, whatever you have to pay the least for and have the most information from, I think is where I take things. Any free apps that are there that are tracking seem to be helpful. I mean, I used to use MyFitnessPal a lot, but now there's a lot of these athletes are looking for human optimization without any sort of financial backing too. So whatever we can do the cheapest is just kind of how I do it. And maybe we'll skimp out on a little bit of quality analytics there, but it gives me a pretty good idea. And oftentimes when we look at the data, like they're so far away from fiber targets, they're so far away from protein targets or overall caloric needs that there's so much room for growth before we get into the nitty gritty of things too.
Last question we have, do you think more female athletes should be on supplemental collagen based on the impact of hormones on tendon, ligaments, and fascia?
It's a good question. It's like an inference point for sure. And some other sides of that too would be, in my experience, not a lot of them are hitting protein targets to begin with. So it's going to build that amino acid pool up a little bit. It's not going to directly create, hit protein targets, but at least that pool will be developed a little bit more. So if there's any like support metrics that we're looking for a baseline of a female athlete, perhaps that would be something that you could add in just as a supportive network, whether that be the mechanism of why we're starting to see these ruptures or not.
Okay. Last chance. Any last questions? I think we're all questioned out. Dr. Nikole, is there anything you want to say as like a send off?
No, just I probably said it a million times throughout this presentation, but just, ask really great questions and treat the person sitting in front of you. And a lot of you have all of this knowledge and know how to treat. It's just more so getting a really good idea of the fluctuations throughout the individual cycle that we're going to start to treat versus treating a cycle itself.
Okay, thank you very much. Anyone who is listening live, there will be a recording posted if you'd like to rewatch this. And again, Dr. Kokes, if people do want to find you.
Yeah, at sports.kokes is probably the easiest access, at SPORTSDOCKOKES. And if you have any questions, don't hesitate to ask there.
Okay, thank you very much.